Okay. Hello, everybody. I'm very sorry that I could not come due to the also to the international situation. My title is Doravirine Added Value in the Current Art Basket. So these are the last guidelines from European AIDS Society, showing that in addition to the second generation INSTI for starting treatment in naive people with HIV, we also included doravirine either as a single tablet regimen as tenofovir 3TC and doravirine, or with TAF, FTC, or tenofovir XTC. You know that I'm the vice chair of the European guidelines section on antiretroviral therapy, and I have to tell you that there was a huge discussion about this because at that time it was not compared with INSTI. Why I'm saying this? Because the trial that has been performed with doravirine in the registration phase were two, where the drive ahead, where doravirine 3TC, FTC, 3TC tenofovir was compared to efavirenz FTC tenofovir, and you see that there was non-inferiority. I mean, the two regimens were absolutely comparable with a non-detectable viral load in doravirine 77.5, in efavirenz 73.6. What emerged immediately was that there were much less CNS side effects in doravirine than efavirenz, as a better lipid profile with a decrease in non-HDL cholesterol and a decrease in triglyceride. This was continued the observation for 192 weeks, and you see, and the one who were enrolled at the beginning in efavirenz were switched to the open label in open label fashion to doravirine, and you see that either those who continue doravirine or those who switch to doravirine maintain undetectable viral load in a very high percentage of participants, 84.9 and 80.3. The few patients who fail, we are seeing in this slide, a couple of them had resistance at failure. While I said the neuropsychiatric was much better. At the 192 weeks analysis, you see that the effect on the lipids was the same, was really favorable. And especially in those who switch to doravirine at a certain point, you see while the column became all green but all negative, so there was an important impact on the lipids. We know that efavirenz is not the best on lipids, but so it's not, but it's important to see that there is an important decrease in lipid when switching from efavirenz to doravirine. Also the weight, we had a small increase in weight that was very similar between either the one who started doravirine and efavirenz and the one who switched to doravirine and efavirenz. So after 192 weeks, you see that the weight gain was really a small weight gain, absolutely small weight gain. The other randomized study was the drive forward study, where doravirine was compared to darunavir. And also in this case, we have seen the result at the 92 weeks. We see that there was no difference between the two arms, with 73.1 versus 66 in the darunavir arm. And because there was a high rate of discontinuation, much higher if you see in the darunavir arm compared to the doravirine arm. There was no difference among the different population concerning the possibility to reach an undetectable viral load, while obviously if it was relevant with the favirenz, it was even more relevant with a boosted PI. We see that the lipid profile was absolutely much better. This is the results in as I show you in another, this is the study that was done exactly the same with the drive ahead, so the prolongation F at 192 weeks, and you see that the level of suppression in both arms was very high, was about 81% at 192 weeks. And also the lipid profile was really much, much better and continued to decrease also along the time. Much better, obviously, in those who switch from the boosted PI. So a good efficacy, virological efficacy, and a very good lipid profile. Also in this, compared to darunavir, we see that there was no difference in weight gain between doravirine and darunavir. You know, from the analysis of the trial conducted by Paul Sachs on the weight gain, that PIs as efavirenz at that time, so NNRTIs were the best in non-weight gain. So I think that it's reassuring that there was no difference among them. There has been also more data obtained in this 192 weeks analysis of those who started and continued doravirine, or those who switched either from efavirenz or from darunavir kubicistat. And what we have seen that there was a decline in eGFR, observing a few weeks from starting doravirine. And this was independent from the use of tenofovir, because you remember that could be either tenofovir or TAF, but because it has been studied, and that it's very similarly to what happened with dolutegravir, we have an inhibition of the organic cation transporter 2, OCT2, so the creatinine stays in the blood, and that's why we have a sort of increase in the eGFR. I said that we didn't have, in the discussion that we had in the antiretroviral panel, was due to the fact that many of my colleagues didn't want to include doravirine because there was not a comparison with the second generation INSTI. So these are the studies that are ongoing now. So there are Opti, DOR, and El Dorado. One is from in North America and Europe, and the other one is sponsored by the NRS you see, this one, the first one is conducted in South Africa, sorry, and the second one in France, Brazil, Ivory Coast, Cameroon, Mozambique, Cambodia, and versus dolutegravir, and we will see what they will find. In the meantime, at this CROI, I mean, it has just finished. Jürgen Rockstro showed the data on doravirine, islatravir, that is a new combination that we will have available in I think in 1 year probably, versus bictegravir, FTC, and TAF. I want to show you the data just to tell you how potent is doravirine, because I don't think that this latravir is different from tenofovir FTC. Every time that we conduct a study, the result depends also on the population that we have. This is a double blind, so this is very important, study of doravirine islatravir versus BF-TAF. And this is the baseline characteristics. And we see that like 20% in doravirine islatravir versus 14% in BF-TAF had CD4 count below 200 and a viral load that was the median viral load was 53,000. But there was 10% in both arms with more than 500,000 copies. And you see that here the number of virologic suppression were almost 92 with doravirine islatravir, with almost 91 with BF-TAF. I think that this datum is very reassuring for those who didn't believe in a way in this drug, thinking that it was only a switch drug. I can tell you that these data show us that is also a very good option in naive. And this is the paper that has just been published. I said about the naive, we have also data on the switch, and this is the drive shift study. This is the virological outcome at 144. And you see that the level of suppression that has been maintained was very good, very good. So I think that is good not only for naive patients, but also as a switch strategy. And when we look at the weight gain in those who did an immediate switch or delayed switch, was almost, the same. I mean, very, very low impact on weight gain. And I think that this is something that should be kept in mind, while many other drugs like second generation INSTI has been associated with weight gain. So these are the data, but why do we need doravirine in the art bucket? But I think that doravirine, compared to the other NNRTIs, has a much better, genotypic barrier to resistance, and this is due also to the level of protein binding that is lower, and this is translating to greater potency against wild type viruses and viruses also with common NNRTI mutation, like the one for efavirenz, for example, the 103, the K103. Not only it is active against resistant virus, but also when you use doravirine, the rate of development of resistance of failure is much lower than for the other NNRTIs. I mean, we know that the genetic barrier of an NNRTIs is not the same of boosted PI or of second generation INSTI. But among this class that has a lot of other benefits that I will show you in a moment, we have doravirine is the one with not only active with the in the presence of previous mutation for NNRTIs, for all the generation NNRTIs, but also it develops more slowly the mutation. And what there could be some case in which you could have just one RAM, like Y188L or Y318F, that could be sufficient, that could be enough to determine the resistance to doravirine, but in general, you need at least 5 NNRTI RAMs to reduce susceptibility to doravirine. So very potent and very high resistant barrier. That's why it has been conducted a study on those, and that it was presented at Glasgow, in countries where NNRTIs are probably less used than in your country, so pay attention to this. But they started doravirine without performing the genotype or performing, or having a previous genotype, and you see that there was no difference in having or not a previous genotype in this concerning the maintenance of virologic suppression. But what limits the durability of antiretroviral treatment is are the side effects. We have seen that doravirine can have very few side effects. Among these, just a little bit of sleep disturbances or headache that should be asked to the patient if they have it, but nothing about severe like the hepatitis of other NNRTIs or rash. We know that also second generation INSTI have side effects, not only the weight gain that I said, but also, for example, this is a poster that has been presented at CROI 2026 showing that there is an important, a link in a way with the development of the onset of hypertension. And if you look at this, where you see that there is NNRTI MPI in red in this square and second generation INSTI, you see that the incidence of hypertension was much higher in those treated with second generation INSTI. So take into account also the possibility that there is a link with hypertension or that is less known, but it has been linked recently to INSTI. So think about switching the treatment. Tenofovir, we know, doravirine is combined with tenofovir diproxyl fumarate. We know the risk of renal insufficiency or of bone, osteopenia. What we have seen is that when tenofovir diproxyl fumarate is combined with an NNRTI, the level of tenofovir is low. So all these problems with tenofovir were mostly associated to the use of tenofovir in combination with boosted drugs. So this is really important to know, and you see that the level of doravirine, of tenofovir in combination with doravirine compared to the other drugs is low. So, so no surprising, this has been presented last year in the Italian conference, that when we compare doravirine 3TC tenofovir to other association, for example, BF-TAF in this case, the level of, the bone density was very similar between those treated with BF-TAF and those treated with tenofovir 3TC doravirine. You see there was no difference between the two. So this is very reassuring. And so why? In Italy, this is a study that we have published in the ICONA cohort. We decide to treat to choose people in ART naive to choose doravirine. Usually we start it in people who have a less advanced HIV disease, but maybe sometimes have other fragilities and potential risk factor for comorbidities. So we know that this important, lipid profile that is much better than with other drugs. It's something that is important with people who are getting old. Also because doravirine do not have any drug-drug interaction also with statins, whatever. So it is used in also in people with comorbidities, and we have seen that in these patients. For example, in the one published by Leonardo Calza, between those switching to to Doravirine or 3TC or BF-TAF, we have seen that there was a better an improvement in insulin resistance in those switch to Doravirine. So better lipid profile, the same bone, better insulin resistance, and this is true also in also those who switch, as I said, from the from a second generation Rinsti, so from the most recent drug. So as I said, it's very important to profile someone who could have high cardiovascular risk, because Doravirine 3TC tenofovir in the study that is the Dorothea study that was presented at Glasgow in 2024 showed that those who switched to Doravirine had a decrease in the in the score 2, that is a systemic coronary risk evaluation. So no surprise that we treat people with who are older than 60, and you see that in switch they maintain absolutely the undetectable viral load. Concerning the weight gain, we know the switching treatment, these are the data of those randomized in the advanced trial, who had this very relevant increase in weight with dolutegravir FTC TAF or dolutegravir tenofovir FTC compared to efavirenz. And when they were switched to dolutegravir 3TC tenofovir, there was a small decrease, but not so relevant. Doravirine has been shown to decrease the adipose tissue, the abdominal adipose tissue, but when it was conducted a randomized study to see if in people who were obese, this is the wrong thing, I think, to randomize people who were obese and not only those who gain weight on INSTI. They were randomized to Doravirine TAF FTC or Doravirine tenofovir FTC or INSTI, to continue INSTI plus TAF and FTC, and there was no, I mean, all lose some weight, but there was no difference between the arms. I really think that the fact that they were obese really made the difference. So this is something that we have to keep in mind. There should be done some data on people who are just overweight and not obese. I wrote an editorial on Doravirine that was published on Lancet HIV on the 192 data, and just explaining why, for me, Doravirine could have a place in the sun in antiretroviral therapy, and I really think that what I've shown you now shows you that the metabolic profile is much better. It has the toxicity of tenofovir when it's combined with doravirine is much lower, and also we have to consider that the patient have a much lower weight gain. So in conclusion, doravirine is a next generation NNRTI approved for the treatment of HIV. We have seen that it has a unique resistance profile, so it could be used also in patients who have previous resistance to NNRTI. It is dosed once daily, no food requirement, low potential for DDI, favorable PK profile, and I think it's very effective, and especially in a population that is getting old. It should be used more and more frequently due to the good metabolic profile and better the improvement in insulin resistance. And I thank you for your attention.